Hello, everyone. It's Ulrich Sydney. I'm the president of the Association of Future African Neurosurgeons. Thanks for joining us this Saturday for yet another lecture in our series on emergency neurosurgical pathologies. Today we have two presentations. The first will be by Dr. Nathalie Ghomsi, a first-year resident at the University of Felix Houphouët-Boigny, and the next one will be by Dewin Shishimba, who's a student from Zambia. Before we start, we're going to have presentations from all the attendees. So we'll start with Zolo. Hello, Zolo. Can you present yourself?
Hello, Ulrich. Hello, I am Zolo Ivan. I'm a CTA medical student from the University of Boya in Cameroon. I am a member of the Association of Future African Neurosurgeons. It's a pleasure being with you.
Thank you very much, Zolo. Dr. Dylan Jofak.
Hello, everyone. I'm Dr. Dylan, general practitioner from Cameroon and member of the Association of Future African Neurosurgeons. Nice to meet you all.
Thank you very much. Dr. Khalif.
My name is Khalif. I'm a fourth-year fellow in the College of Surgeons of East Central and Southern Africa, currently at Nairobi at University Hospital, and glad to be here.
Thank you so much, and we are glad to have you. Always nice to have our seniors around. Dr. Stefan Gembu, can you present yourself, please?
General practitioner. Oops. Everybody know how you hear me? Hello?
We didn't get that, sorry.
Okay. I'm Stefan Gembu, medical practitioner from Cameroon, member of IFEN. Glad to be with you.
Okay, thank you so much. Rajiv Nupane.
Hello, doctor. I'm doctor from Nepal, recently practicing in the as a neurosurgeon medical officer, and I'm struggling for the to practice get the training in the neurosurgery in the UK.
Oh, we're glad to count you among us. Dewin Sishimba, can you present yourself, please?
I'm a medical student from Copperbelt University, Zambia. I'm glad to be here. Thank you very much.
We're glad to have you as well. And finally, Dr. Nathalie Ghomsi will present herself, and she will start her presentation right away. Thanks.
Thank you, Sydney. Hello, everyone. I am Nathalie Ghomsi. I'm a medical doctor. I'm a year one resident in neurosurgery in Abidjan, University of Abidjan. Today we are going to talk about extra-axial hemorrhages. Extra-axial hemorrhages. Extra-axial hemorrhages. And in order to talk better about it, we'll follow this plan. After an introduction, we shall talk about extradural hematomas, acute subdural hematomas, subarachnoid hemorrhage, a brief talk on subarachnoid hemorrhage, and then we shall conclude by we should first know that intracranial hemorrhages are hemorrhages within the cranium. They are divided into two different kinds of hemorrhage. We have the intra-axial hemorrhages, also known as intracerebral hemorrhages, which are hemorrhages found within the parenchyma or within the in the intraventricular space. We also have extracranial hemorrhages, which are hemorrhages which are found within the cranium but outside the parenchyma of the brain. They are usually found within the meningeal spaces. We have the extradural hemorrhages, the subdural hemorrhages, and the subarachnoid hemorrhage. The brain is protected inside the skull by three separate layers. The meninges. We have the We have from the innermost layer to the outermost layer, we have the pia mater, which lies just on the parenchyma of the brain. We have the arachnoid hematoma here in purple color, and then we have the dural matter. The dural matter is divided into two parts. We have one part which is which lies directly on the periosteum, that's the skull, and we have a second part just underneath it, the meningeal dural matter. These layers define three potential spaces for blood collection. We have the epidural space, which is found between the skull and the dural matter, that's the periosteal dural matter. We have the subdural space, which is found between the dural matter and the arachnoid layer. And then we have the subarachnoid layer, which is found between the arachnoid matter and the pia matter. We shall first start by talking about extradural hematomas. These are collections of blood which are found between the potential space that exists between the inner table of the skull and the dural matter. That's the periosteal layer of the dural matter. The extension of the hematoma is usually limited by the suture lines, as you can see here. The hematoma is being limited by the sagittal suture on top and then the squamous suture beneath. This is due to the light attachment of the dura to these different locations, as sutures. It represents approximately 2% of all brain injuries, and amongst which 5% to 15% of patients with fatal head injuries. It can be found in an acute form, a subacute, and a chronic form. It occurs mostly in young adults and are very rare in children less than 2 years due to the plasticity of the immature skull of these children. They are also mostly found in patients less found in patients greater than 60 years old due to the adherence of the dura mater to the underlying bone. The incidence of delayed extradural hematomas following initial negative CT scan is also reported in 10 to 30% of cases. How are these extradural hematomas formed? When we have a trauma, there is a brief linear contact force to the skull that causes a separation between the periosteal layer of the dural matter and from the bone. This also leads to a disruption of the interposed vessels due to shearing stress. In 85 to 95%, we will find of these cases, we will find a patient with a fracture of the underlying skull. Chronic and delayed manifestation may also occur. That is when there is a venous source involved. The middle meningeal hematomas arises from injuries to the middle meningeal artery in over 50% of the patients. We can also find an injury of the middle meningeal veins, diploic veins, and torn dural venous sinus. As we said earlier, a fracture of the temporoparietal region may lead to middle meningeal artery, to a rupture or an injury of the middle meningeal artery, which will lead to, which is the main cause of extradural hematoma. Though we can also find other locations such as an injury in the frontal bone will lead to an anterior ethmoidal artery injury, bleeding. An occipital injury may lead to a transverse or sigmoid sinus bleeding, and we can have a superior sagittal sinus bleeding if the trauma is at the vertex. The main clinical presentations of the extradural hematoma has 3 phases. We have a brief post-traumatic loss of consciousness for the initial impact. Secondly, the patient will find himself in a lucid interval for several hours. This interval is the interval where the patient doesn't complain of any. The patient doesn't complain of any symptom, neurological symptom of deficit. And then secondly, the patient will find himself with a contralateral deficit, ipsilateral pupillary dilation due to the mass effect from the hematoma. Other clinical presentations could be seizures, elevated CSF pressure, ipsilateral hemiparesis. It could also have what they call a Kenohan knot phenomenon, To simply explain, the coherent notch phenomenon is a situation where the patient presents ipsilateral symptoms, ipsilateral deficit due to the compression to the lesion, due to the compression of the hematoma on the contralateral parenchymal brain, to the compression of the contralateral brain, parenchymal brain on the skull, on the other side. That's the patient will have first localizing sign. We have a patient who has a right, for example, a right extradural hematoma, and we find himself having a right hemiparesis. It should be noted also that in pediatrics, and a drop of 10% of the hematocrit after admission could also we should suspect extradural hematoma. The radiological diagnosis is usually the exam used to determine how the surgical indication or non-surgical indication, or in fact to determine the type of management to be used. It is usually easier to see. That's, we have a patient with a biconvex here, well, for example here, we have a biconvex or lenticular shaped hyperdensity, homogeneous hyperdensity, that does not crosses the suture. Here we have the sagittal suture and it doesn't crosses the squamous suture beneath. The management of extradural hematoma could be either conservative or surgical. The main indications, surgical indications, are a volume of hematoma greater than 30 centimeters cube, a volume of hematoma greater than 30 centimeters cube with a thickness of 15 millimeters or a midline shift of more than 5 millimeters. If this patient doesn't present all these criteria, but has signs of herniation, cardiorespiratory abnormalities, azochoria, and has a severe traumatic brain injury, then the patient should be operated. The techniques of surgery is usually a simple craniotomy with the evacuation of the hematoma. Volume of less than 30 centimeters cube, thickness of thickness of the hematoma less than 15 millimeters, and a midline shift less than 5 millimeters. A non-severe brain injury and no focal neurologic deficit can be managed non-surgically if with serial CT scans being done and a close neurosurgical observation in a neurosurgical center. Secondly, we shall talk about acute subdural hematomas. Acute subdural hematomas is a collection of blood between the inner layer of the dural, as you can see, inner layer of the dural matter, but it is external to the brain and to the arachnoid. It is the most common traumatic intracranial lesion, and it occurs in 29% of traumatic brain injuries. It is motor vehicle accident is the main cause in young patients. Here we have a high magnitude, during the trauma we have a high magnitude, magnitude of impact damage as opposed to secondary damage. It is usually much higher in acute subdural hematoma than epidural hematomas. Which generally makes this lesion more lethal than epidural hematomas. It is usually also accompanied with other underlying brain injuries such as diffuse axonal lesions. The mechanism of the injuries varies between the age groups. Most subdural hematomas are caused by vehicle-related accident, as we said earlier, but it could also be caused by force or assault. The two common causes of traumatic acute subdural hematomas are accumulation. Firstly, accumulation around the parenchymal laceration. There is usually a severe underlying primary injury. In these cases, the patient will present with no lucid interval. Focal signs usually occur later and are less prominent than epidural hematomas. Secondly, it could also be caused by surface or bridging vessels torn from cerebral deceleration and acceleration during violent hand motion. Yeah, with this etiology, primary brain damage may be less severe. A lucid interval may occur with later rapid deterioration. As for its clinical presentation, they are usually severe, with the patient finding himself with a low Glasgow Coma scale. The patient is usually having a severe traumatic brain injuries. The patient may also have associated lesions such as diffuse axonal lesions or brain herniation. As you can see, we have already a brain herniation. There's a midline shift, an important midline shift. An enhanced CT scan is also the exam of choice. On an enhanced CT scan, we had a patient of 30 years who had a motorbike accident. And you can see this lesion, and on this unenhanced CT scan, a crescent-shaped homogeneous hyperdense extra-axial collection. It doesn't have any limits. It is not limited by any suture, contrarily to the epidural hematoma, but it is limited by the dural reflection, that's in the interfacing space, for example. MRI could also be carried out, but it is not the exam of choice in front of this patient because MRI really takes time. It really takes much more time to be carried out than the CT scan. So, but it's not the exam of choice. The management could also, just as epidural hematoma, it could also be surgical and non-surgical. There are surgical indications. One of the surgical indications, which is an absolute indication, is a thickness of the hematoma greater than 1 centimeter or midline shift greater than 5 centimeters, regardless of the Glasgow Coma scale. A patient which presents itself, though other indications which are relative indications could be taken, such as patient who presents himself with a severe traumatic brain injury with lack of the ability to localize on motor response. He should undergo ICP monitoring. Patients which comes with a brain injury, a severe brain injury with a thickness of the hematoma less than 1 centimeter and midline shift less than 5 millimeters should undergo surgical evacuation if the Glasgow Coma scale decreases by 2 points, if there's abnormal pupillary examination, or there is sustained increase in intracranial pressure above 20 millimeters despite medical therapies. Here, I'm going to elaborate. This is a patient we received, the patient we received with he had a right subdural, acute subdural hematoma following a car accident. He was 32 years old. So when the patient arrived, he was at a Glasgow outcome scale, Glasgow Coma scale of 8. So emergent CT scan was done, which found this hematoma, this voluminous and large hematoma, subdural hematoma, panhemispheric hematoma. So what do? We carried urgently the patient to the theater where we did an osteoplastic craniotomy using a jiggly saw. Using a jiggly saw, as you can see, after a burr hose, we used a jiggly saw. And then secondly, we did a cruciform incision on the dura mater, and then we started draining the and washing off the. Oh, sorry, this is supposed to be. Let me stop share. Let me just put it back. It's supposed to be a video. Oh. Stop. Okay, let me just no. Okay. So I don't know if everybody can see.
Yes, we can see.
Yes, we can.
Thank you. So that's the hematoma. It was really a voluminous hematoma that remove that at emergency. It's just that maybe I should have taken a better video of around the hall so that you can see in which conditions we operate these patients. We don't waste time. Usually our emergency unit is not really, how can I say, appropriate, but everywhere we can be, we can do this surgery. Even general practitioners are taught to do this surgery since we don't have neurosurgeons everywhere in Cameroon. So if he has the appropriate equipment, he can also do this. After that, we wash the hematoma with saline solution. This is so that we can remove all the products of degradation of red blood cells of blood. It was bleeding. We have this cortical artery, which was bleeding. So after doing that, we will try to cauterize the cortical artery with the electric destroy. Then lastly, I won't really talk much about this because it was already done by Dr. Ghomsi, I think 2 weeks ago. We shall talk about subarachnoid hemorrhages. These are hemorrhages where there is a lesion of vessels found between, as we said earlier, between the arachnoid space layer and the pia mater. The main causes are the stomach is the main cause of subarachnoid hemorrhage, but it could also be spontaneous, where aneurysms, ruptured aneurysms present 75 to 80% of this hemorrhage. We should also note that this subarachnoid hemorrhage incidence varies worldwide, ranges from 1.1 to 82.3 per 100 persons per year. And it is lowest in the Middle East and highest in Japan, Australia, and Scandinavia, especially in Finland. The sex ratio is 1.6 females to 1 male. Its clinical diagnosis, we have in the clinical presentation, we have 3 main presentations. The patient will present himself at the hospital with a thunderclap headache, a sentinel headache, that's the headache which occurred 6 to 8 weeks earlier, and which was spontaneous, that is, it was coming out spontaneously and being resolved spontaneously. Or he may also present with sudden death. There are usually no focal signs, neurological signs due to except if there is a complication. The patient is usually comes with signs of meningeal irritation. Thus, we have the patient with head stiffness, neck stiffness. We have the Brudzinski sign, the Brudzinski sign, and the Koenig sign. The patient may also present himself with the seizures. When the patient presents with these symptoms, usually what we do is we do a lumbar puncture to look at the quality of the macroscopic quality of the CSF, of the cerebrospinal fluid. It could be xanthochromic, that's this color. It could also be very bloody, which really signs subarachnoid hematoma. Or could also have this pinkish color. When it is xanthochromic, it is the product is hemoglobin. That's the degradation. The degradation of this due to the presence of bilirubin which is a product of degradation of hemoglobin from the red blood cells. We can also have different clinical presentations depending on the anatomic situation of the rupture, of the aneurysm rupture. Patients who present themselves with third nerve palsy usually indicate an aneurysm at the junction of the posterior communicant artery and the internal cerebral carotid artery. If a patient presents himself with transient paralysis of one or both lower limbs, it suggests an aneurysm, a ruptured aneurysms of the anterior communicant aneurysms at the paracentral lobula. If a patient presents himself a hemiparalysis with hemiparalysis of aphasia, it usually suggests an aneurysm of the first major bifurcation of the middle cerebral artery. The patient also may present himself with blindness, sudden blindness, which usually signs an aneurysm that lies in the anteromedial part of the circle of Willis. The WFNS came out with a classification which helps, a clinical classification grading, which helps in the prognosis of patients with subarachnoid hemorrhage. This clinical classification, prognostic classification, depends on the Glasgow Coma Scale and the motor deficit. Patients with grade 1 usually have Glasgow Coma Scales, which is at 15, without any motor deficits. Grade 2, the patient will present with a Glasgow Coma Scale between 14 and 13, without hemiparesis, without a motor deficit. As for grade 3, the patient will present himself with a Glasgow Coma Scale between 13 and 14, but we have either motor deficits or nerve palsies. A grade 4, the patient will present with a Glasgow Coma Scale between 7 and 12 without any motor deficits. While grade 5 will be patient between 6 and 3, with or without, regardless of for grade 4, it's a patient who will present with a Glasgow Coma Scale between 7 and 12, regardless of any motor deficit. While grade 5 is a patient who presents himself with a Glasgow Coma Scale between 6 and 3. The CT scan, on-exam CT scan remains the exam of choice for this pathology. It has a 98% sensitivity. As we can see here, we have a spontaneous hyperdensity of the subarachnoid space. That is diffuse, everywhere is being infiltrated. And Fisher came out with a prognostic image classification. This classification will help in the decision of management. It depends on the thickness of the subarachnoid hemorrhage, associated or not with interventricular hemorrhage. For example, patients who have a 0 grade are patients who do not have, where there is no subarachnoid hemorrhage seen on CT scan nor interventricular hemorrhage, while those with grade 4 are patients who have a thick subarachnoid hemorrhage with intraventricular hemorrhage in both lateral and lateral ventricles. So this is a hemorrhage, subarachnoid hemorrhage in the middle cerebral artery territory. Other diagnosis could be done if a patient presents himself with a grade 0, but there are clinical signs which are falsely suspicious of subarachnoid hemorrhage. We can do a puncture of CSF, as I said earlier, where red blood cell counts will be up to 1 million per millimeters cube. It will have a xanthochromic color due to the presence of bilirubin in the CSF. Vessel angiography could also be done, which will localize and define the anatomic details of the aneurysms. Subarachnoid hemorrhages are usually accompanied with 4 major complications. These 4 major complications are usually the cause of delayed neurological deficit. As a patient presents with secondary neurological deficit, which he didn't have at the beginning. We have firstly hydrocephalus, which is caused by the obstruction of CSF flow by clotted blood. It can occur either early, where the surgical management will differ. If it occurs early, we will do an external ventricular derivation. While if it occurs late, we can do a ventricular peritoneal shunt. But while doing this drainage, care should be taken because a reduction in intracranial pressure can also increase the risk of rebleeding. As for rebleeding, it usually occurs within the first 24 hours. Up to 20% of patients rebleed within 2 weeks. The main preventive measure in control of blood pressure is the control of blood pressure by beta blockers or calcium channel antagonist. An alternative early clipping of the aneurysm allows hypertensive and hypervolemic therapy to prevent vasospasm. The third is the vasospasm itself. What happens is when there's a rupture of an aneurysm, the blood liberated. There are products in the vessels which will go and which are vasoconstrictive. It will cause a vasoconstriction of the underlying vessel where the blood will find itself. So the patient may have neurologic deficits from cerebral ischemia. And usually vasospasm occurs between the 4th and the 12th day after the subarachnoid hemorrhage. The main treatment used here, and which has clinically proved that improved the outcome of these patients, is nimodipine, a calcium channel antagonist. This patient will also find himself with hypothalamic dysfunction. This is caused by excessive sympathetic stimulations. This sympathetic stimulation may also lead to myocardial ischemia, or we have a labile blood pressure. Hyponatremia is frequently found in these patients. Hyponatremia is also frequently found in this patient due to a salt wasting or inappropriate secretion of antidiuretic hormone. This patient also may be subjected to pulmonary edema, which could be neurogenic or non-neurogenic. As for its management, the main aim during the management of subarachnoid hematoma is to protect the airways, to manage the blood pressure in order to prevent an elevation of the ICP, to prevent rebleeding, to manage the vasospasm, to treat hydrocephalus, the complications such as hydrocephalus and hyponatremia, and to prevent pulmonary embolus. These patients are usually advised to have bed rest in a quiet place, and they are being put on stool tougheners. This to prevent bleeding by the increase of the vasovagal maneuver, which may also increase the intracranial pressure. The adequate hydration is necessary to avoid a decrease in blood volume, predisposing to brain ischemia. Mannitol is used to control the ICP. As for the blood pressure, as we said earlier, inhibitors, calcium beta blockers or calcium channel inhibitors such as nicardipine can be used to maintain the cerebral perfusion. In order to maintain the cerebral pressure, the cerebral perfusion pressure at 60 to 70 millimeters mercury. Phenytoin is usually used to prevent seizures, which are really frequent to these patients. As for the management of vasospasm, these patients are usually put on 60 milligrams oral 60 milligrams of every 4 hours of nimodipine. We should note that no situation should prevent the administration of this nimodipine. If the patient can't swallow, we can put the patient nasogastric tube so that we can send nimodipine through the nasogastric tube. Now, finally, talking about the interventional treatment, after the patient has been stable, we can now proceed to surgical repair with a clip, endoscopic repair with platinum coils. As for me, I've never seen this repair as endoscopic repair, but I'm a little bit used to a clip. The use of a clip that is through Professor Ipe and even locally in our country. So this is just a summary of the management of the different complications that we can have. In conclusion, what I'll say is that extracranial hemorrhages are neurosurgical emergencies. The lucid interval constitutes a main but not pathognomonic clinical characteristics of extradural hematomas. Acute subdural hematomas has a higher mortality rate than extradural hematomas, and always think of subarachnoid hematoma in front of a thunderclap headache. The management of extracranial hemorrhages is usually multidisciplinary, involving the neurosurgeon, the anesthetist, the cardiologist, and the other re-educating personnel. The surgery indications usually depends on the Glasgow Coma scale, the thickness of the hematoma, the midline shifts, and the secondary monitoring of intracranial pressure. I thank you for your attention.
Thank you so much, Dr. Nathalie. That was a great presentation. We'll now open the floor for anyone who has questions or comments.
Hi.
Hi,
Great. Hi. Great presentation, Dr. Nathalie. Really very extensive. I did every part of it. Great presentation.
Thanks, dear. Thanks, Dylan.
So you briefly mentioned the other modalities of treatment for subarachnoid hemorrhages. So in cases of aneurysms, like you rightly said, you can use clips, and there are other technologies available today besides clips. You have, obviously, you spoke about the coils, but you can equally have flow diverters. The concept behind flow diverters is you're trying to modify the rheology, the flow of blood in the aneurysm. So you're going to slow down the flow of blood, and when you slow down the flow of blood, you have stagnation, and then you can equally have another way you can use these devices is to engender, I would say, so to promote reconstruction at the level of the vessel wall. So you can equally do some reconstruction of the wall, and this will obviously take more time. So if the risk is more imminent, then you're more likely to go with, it's better indicated for you to go with clipping than coiling. So there's this discussion nowadays about clipping versus coiling, and I think it's the perspective is different from whether you are in a high-income country or whether you're in a low and middle-income country. A lot of studies have come up with superiority of endovascular techniques, that's coiling, flow diverters, for example, versus open vascular, which is the clipping technique. And a few people like Professor Ibsheran have argued that the problem with endovascular technique is they are very expensive. In an LMIC setting, they are not necessarily the most adequate or indicated modalities. Other people argue that you can have endovascular suits, not just for neurosurgery, but for cardiovascular as well. So that when you have those two, for example, working together with peripheral surgeons as well, then you can bring down the cost, and you can be using those suits quite often. So it's interesting. In the US, they train neurosurgeons to be dual surgeons. They do endovascular and open vascular. So you have some surgeons, for example, at Brigham here at Harvard, that's a lot of the vascular surgeons do both. They do both endovascular and open vascular. It's very interesting because they are the same people doing it, so they can give you the reasons why they do one and not the other. But in other countries, usually it's the interventional radiologist that does the endovascular, and then you've got the neurosurgeon doing the open vascular. And in that sense, you might not necessarily have the best of, you have a conflict of interest usually. That's the best way to put it. And there was a really good conference where we had the older guard of vascular who have been proning and promoting clipping versus coiling. And the problem today is most of those trained in the US are trained mostly to do endovascular technique. And clipping cases are really the complicated cases, like really complicated. And so you get the really experienced people doing the really complicated cases in such a way that when you finish your training, you've not done that many cases of clipping. So you probably the first time you fall on a case of clipping will be the most complicated thing you can imagine. And there's this story about Spätzle, who speaks about clipology, Michael Lawton and Spätzle, they speak about clipology, and having us, the younger generation, train more and more on in the lab to have that skill. And it's interesting. It's really good that you had this. You brought up all these points, and I think this is where us, as the future African neurosurgeons, we have to think about these things. Like, where do we see neurosurgery in 10 years, in 20 years? Are we going to be doing the same things as the US or the rest of the Western world? Personally, I don't think so. And I think we need to know these things and take the right decision. That was the comment I was going to add there. I think Dr. Khalif has something to say here.
Yeah, that's a very interesting discussion you're having, Ulrich. The issue of subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, is a very, very underdiagnosed and undertreated problem in Africa.
Yeah.
Let's take, for example, in Kenya. Our last census, which came out last month, shows that we have 47 million Kenyans in this country. So if you take the general incidence of aneurysms, that is around 1 to 2% of the population are walking around with aneurysms. So that gives us around 470,000 Kenyans with aneurysms out of the 47 million. And then of that, 1% will rupture every year. So in Kenya, according to the statistics of all the major studies that did population studies on aneurysms, we have at least 4,700 ruptured aneurysms in Kenya. Yes, how many of those are diagnosed and treated? Less than 500. In all major neurosurgical centers, which are around 5 in this country, we don't even see 500 cases, which means these patients go to our hospital, they complain of severe headache, somebody treats them for malaria or meningitis or some funny things, they go back home and they die. So what kills these patients? Before I come to the discussion that was leading, what kills these patients? The first thing that kills them is rebleed. They bleed within 3 days. The first time, the first rupture, 15% of the patients will die on the spot. They don't make it to the hospital. So that gives you around 85%. Of this 85%, another 30% will die within 4 weeks of other complications. If they survive pre-rupture or rebleed, then what kills them is severe vasospasm, hydrocephalus, the other complications of ICU care, of pneumonia, and DVT and stuff like that. So this is a very, very high mortality, morbidity disease that is underdiagnosed in this region of the world. So as young people who are training with these things, we need to be aware of it. Because one of the things that is happening is even the doctors, the general doctors, are not aware of what is happening with these patients. They are not diagnosed on time. Nobody does a CT scan. If you do a CT scan and you find that the CT scan is normal, you should do a lumbar puncture to rule out subarachnoid hemorrhage. That rarely happens, at least in Kenya. And I'm thinking that's the same for the entire continent. So these patients, what kills them most is rebleed. So that discussion of do we need to coil them or do we need to clip them is a little advanced for us as of now. Whatever form of treatment you have, prevent the rebleed. That is the most important thing. If you can clip and you cannot coil, please do the clipping. If you are fortunate enough, like the center in which I am, we're doing both coiling and clipping. We have 70% of our patients are coiled and 30% are clipped. We have a neurosurgeon from South Africa who's very, very experienced in both ways. So very fortunate, but we don't get those many patients because we don't get the referral on time. Patients die. So the most important thing is not whether to use clipping or coiling for us as Africans. That discussion we'll have it later when at least we have both options. The most important thing is at least treat these patients. Take them to theater. Don't wait for 2 weeks. Clip the aneurysm. That will save lives. That's the most important thing. And the second part of which one is superior, clipping and coiling, that question has already been answered. It's clear. Everybody knows that coiling is superior to clipping, but unfortunately, it is capital intensive. You need the infrastructure, you need the personnel, you need a lot of things. But that question has already been answered in several studies, in the ISAT, in Barrow study, which some of these, and many other studies that had to be stopped because they found out that the modified rankin scale of patients who were coiled was much, much superior to patients who were clipped. So that discussion we're going to have as Africans, as you're saying, our main priority is to learn both ways. We don't have that luxury of guys in where you are, where Sydney is right now, that you can choose which one do you have. Do you want is this aneurysm coilable or is it clippable? That is not available in many African countries. So the most important thing is have both ways. If you are lucky and you have the services, go ahead and do most of the coiling. But if you don't sit on these patients. Don't wait for the old teaching of like you have to wait for 2 weeks until the vasospasm clears. No, they will die of rebleed. Clip the aneurysm. That's what I'm going to say. But the other thing that is important is that it's not just the surgery. The post-op care is also intensive, and that's another thing that we need to worry, critical care for these patients. And as you've seen, their outcomes is not as good as other patients. They get profound cognitive decline. If you do their mocha score in 1 year, these guys they can dress, they can eat, they can walk around, but they are completely changed. They can't do any high functioning job. So it's a devastating disease. It's actually worse than subdural hematoma. It's worse than epidural hematoma. It's worse than any other hematoma of the brain that we can think of. That's what I'll say.
Yes, thank you so much, Dr. Khalif. You hit all the points there. And adding to this, I think one of the biggest things with us in this group and the platform is that we need to build a community and learn what others do, because there's usually this bad way of thinking in that certain things are only done in the US, for example, or in Europe. If you know people around Africa, then you find out, for example, that on the continent, some people are doing, say, endovascular and clipping, and you can travel, speak with these people, ask them how they do it, how they arrange, because there's certain things, we've all noticed there's certain things beyond the neurosurgery. There are a lot of things we need to figure out for ourselves. When you go and train, you come back, usually you have this department where you're really high up, you have to do administration, you have to do management, and you still have to be able to operate. Or sometimes you come and you're the only person, you're the one reading the scans, you're the one doing the ICU guidelines. So it means the neurosurgeon, the African neurosurgeon for tomorrow, is not just the person who's apt in the OR. You can do the greatest intervention ever, but if you don't have the right ICU, you get really terrible results. So that's why we need to engage. We need to get more people, to learn these things, to understand these things, like the disease, like Dr. Khalif said. You should be able to recognize these things. And that means your classmates, for example, for those who are medical students, even if people don't recognize this, you being here, you should be like, I think this might be a subarachnoid hemorrhage. That's where we need to start. We need to start speaking about this, recognizing it, because most people think this is a disease that exists just in like fancy books, but it's not the case. People are dying from it. We just need to be able to recognize it. Thank you so much, Dr. Nathalie. If anyone wants to comment again, we still have 11 minutes before we start the next presentation.
Yes, hello everyone.
Hello.
Yes, I have this question. Yes, I have this question, like, because when Dr. Nathalie was presenting, she spoke about sentinel headache, and if you
Sorry, Zolo. If you're hearing me, your connection is not great. So if you can cut your video feed, then maybe we'll be able to hear you. Yeah, I think he's disconnected. If anyone else has a question, why we'll wait for him to come back.
Yeah, sorry, I missed
have
that. The sentinel headache thing that I was asking about. It usually happens within 2 weeks before main rupture. It's a telltale sign of bad things about to happen. Unfortunately, everybody misses it. Patient complains of funny, severe headache that goes away within. That means that the aneurysm has leaked just a little bit, just a little bit. That's just a bad sign. It means that it's going to rupture. So if you have a patient who is known to have an aneurysm that has not ruptured, and then they present with such, if they present with such, sorry, let me just connect my. If the patient presents with such then that aneurysm needs to be taken care of.
Okay. Then I just wanted to ask how will you know? Because the real truth is that us here we don't really do exams just like that. In Africa in general, I don't know how it's in Kenya, but here in Cameroon, when you ask the patient to do an exam, go and do an MRI, go and do this, the argument, he argues with you. You have what you call the syndrome of argument with the doctor. That's the patient knows better his pathology than you. When you tell somebody that he has this headache that is just transient, that comes and then goes, go
Yes.
and do an angio scan, go and do this, the patient will just like, that doctor is not a good doctor. That's the first thing.
Yeah.
Something like that. So
Yeah, Nathalie, what we need to do is you just need to do the right thing. If somebody presents with the worst headache of their life, just tell them that your life might be in danger. You just go do a CT scan. It's $50, $60, $80, $100. It is going to help me treat you. So if they refuse, then that person has done has made a conscious decision of not following your instructions. But you have to tell them. You have to tell them if this is the worst headache of your life, it might be something called ruptured aneurysm, and we need to test you for that. Yeah.
is that
I know
I'm talking about
And the other thing is why that happens mostly, patients are paying out of pocket. And that is a problem with most African countries. We don't have a universal healthcare.
Yeah, I think the network is not great. Well, I'm sure he'll be back shortly.
Can you hear me?
Oh, now we can hear you. Yes. Oh, now.
okay.
Yeah, so
I was just asking myself, I said, yeah, that in our countries we don't have enough neurosurgeons to cover the whole territory. And so, what do you think about the idea of general practitioners being formed to evacuate hematomas, intracranial hematomas?
So this is it's a fantastic question. There are a few points that have been raised here, and they go beyond the simple practice of neurosurgery. And this is what we call today global neurosurgery. Global neurosurgery is about bringing access to people, access of neurosurgical care to people that need it. This access has to be affordable. This access has to be timely. This access has to be safe. So how do we make sure it's affordable? That's what we're mentioning. People paying out of pockets. We cannot have people paying out of pocket because, well, one thing, health costs money. Someone has to pay for it. And unfortunately, health, unlike many other things, health happens when you don't expect it. The truth is, no one, only a few people on this earth will be able to take care of their health expenditures at any time.
Yeah.
Few people have money saved somewhere And this is why everywhere people get insurance, because when health hits, then you have to pay a lot of money. And in this insurance, the objective now is to have universal health coverage. So us as future neurosurgeons, we have to get involved in these talks. We have to make sure that when they define the universal health coverage, because the problem is not just to say we have universal health coverage. In the universal health coverage, they will not cover everything. They will choose a few diseases, a few interventions. So if neurosurgeons are not there when they're choosing the diseases and the interventions, then you will have everything, but no neurosurgery. And what we need to understand is we need to propose those conditions for which, for example, a lot of people are touched, or the few people who are affected by the diseases are severely hit. They might be dead, like is the case with subarachnoid hemorrhage, or maybe they're just disabled. So those are the ones we need to choose, because everyone will be proposing, like rheumatology will be like, oh, we need you to cover this. Cardiology, is general surgery, neurosurgery has to be able to be like, these are the diseases we need you to cover. And we know, for example, traumatic brain injury, like that's the big thing. Okay, so even if we had to choose just one, traumatic brain injury, if you're talking about pediatric neurosurgery, then hydrocephalus. And that's how you go. You keep going and you choose one, and then you propose. That's for the affordability. For the timeliness, people have to have geographical access to this care. So it doesn't matter if you have this one center in a country which does fantastic neurosurgery, but it is, say, 16 hours by road from the furthest person. Then the furthest person, if he has a disease that necessitates to be taken care in time, will have difficulties getting there. So that's one thing. The other access is about the reference system, and this is where we have problems. In most of our countries, any patient can get up and just go to a reference hospital.
Yeah.
People don't go from primary healthcare to the reference hospital. So at the end of the day, what you have is the reference hospital has so many patients, way too many patients for itself, while the primary health centers don't have that many patients, or don't even have patients at all. So if we need to work in each of our countries, you need to understand how does the reference system work now, and you need to be there and advocating that we all need to set up a good reference systems. People should not just go to the provincial hospital or to the regional hospital. That's not how things should work. If you keep doing that, then you have your neurosurgeon spending time with someone who has a headache because they didn't sleep because they had to take an examination, instead of spending time with someone who had a headache because he's having a subarachnoid hemorrhage. So that's one thing we all need to work towards. We have to work so that we set up this reference system, and that means even ourselves, even among our colleagues, people need to understand when to send a patient to the next level and not delay the patient at the level. So you have a hospital that can take care of a subarachnoid hemorrhage and you're keeping the patient for 12, 21 days. If you can't do anything for the patient, let the patient go and tell them where they can meet people. But equally ourselves, it's not because you're a neurosurgery resident or a neurosurgeon that you shouldn't be talking to other people. People should know you. People should have your number. People should be able to access you. So someone might be a primary care physician in a remote village, and he should be able to be like, hey, doc, I have this. And from what you hear, you're like, I think this patient should come straight up, and I have a bed for him, for example. So if a patient is living 300 kilometers away to come to your hospital, and we all know this, you send a patient to the capital city usually, and then they get there, there's no bed. Or you send a patient, they get there, there's no bed in the ICU, so he cannot go into the OR. We need to, even if we can't get to that highest level of organization, we can do these things. You can have WhatsApp groups where you're speaking, neurologists are speaking with neurosurgeons. A neurologist is like, we have this patient, can you take him? And vice versa. So that's the other thing. We spoke about affordability, we spoke about timeliness, now we have to speak about safety. If what you're suggesting is being done and is being published, and in neurosurgery, there's papers that have been published by Dr. Faith Robertson, who is currently an PGY1 resident at Massachusetts Grand Hospital, one of the Harvard hospitals. So Dr. Robertson studied task shifting and task sharing. I'll share the papers in the WhatsApp group. You can read about this. And she basically did a survey on people's impressions. Task shifting will happen, and it is happening. We all know that. The problem is, how safe is it? It will happen, and it is happening because you cannot take a neurosurgeon who's trained for that many years and send them, for example, to the most remote villages. One, they don't have access to that many patients. Two, they don't have the resources, so they will have to stay in the bigger centers. So if we're talking about accessibility, then those who are remote have to be able to get some care, especially when it is within a time frame. So you have certain diseases like stroke. Stroke, you have a time period during which you have to do something. Traumatic brain injury, you have a time period, a golden hour during which you have to do something. And if you don't do something, then the patient starts losing points. So we need people like general practitioners or general surgeons to do these operations. Now the question is, how do we train them to do it the right way? But equally, the other question is, how do you train them so that they understand what they can do and what they cannot do? Because that's usually the problem, right? Let's take obstetrics. We all know this. In most of our villages, you know of people giving birth but nurses are helping them and all that. But we've all gone through OBGYN. There are certain births that are really easy, and then some of them that just get complicated really quickly. You just have postpartum hemorrhage, and the next thing you know, you need a gynecologist. So you need people to recognize that I can do this and I cannot do this. And if I get to this limit, I cannot do anything, I need to send the patient off. So all these things, we have to define them. So the idea is out there, the idea is being studied, and I invite everyone to participate in this discussion.